their toll on the family, on the child itself, and they have social and economic implications. So it is good for us to update ourselves on the various aspects of this condition. And I have the greatest pleasure in welcoming everyone to this group. As you have been told, we try to be very punctual at this meeting. We are known for that. We start exactly on the dot of 3, and we hope to complete the program at 4 o'clock without delay. So on that note, I would like to hand over to the moderator of the session, Dr. Rashidat Ibrahim, to carry on with the proceedings of today. Thank you very much.
Thank you, sir. Good afternoon, senior colleagues. If sounding the chairman's prayer. Well, welcome to today's entitled "The Asthma and Allergy is Germane," and I'll please request us the house rules. The housekeeping rules is that we should all be muted. Any questions should be noted down so that at the end of the day, we'll be able to ask the speaker. That will be compiled, and questions and answers will be noted at the end of the presentation. Please take a seat and let's welcome Professor Ayuk. Time is not on our side, so that we'll listen to the presentation. Professor Ayuk, please welcome you to start your presentation.
All right, thank you. Thank you, everyone. Share my screen now. All right, good afternoon, everyone. I stand again on existing protocol, and I thank you for the opportunity to share this very important topic with all of us. And given the time frame, we'll do our bit to concentrate on the important things. Today, we'll be looking at asthma and allergy, the interplay, what the practitioner needs to know. Adez Ayuk is my name, and I work in UNTH Enugu. I have no conflict of interest to declare with regards to this presentation. And we'll be using this outline to discuss together. We'll look at an introduction. We'll remind ourselves what our take-home will be, really. Remember, there's a lot to talk on allergy and asthma, and 45 minutes wouldn't do justice, but we need to remind ourselves what it is that must be important for us to take away as we go. We'll talk briefly on asthma. We'll discuss why we're concerned about comorbidities when discussing asthma. We'll look at the comorbidities that exist and talk a bit about the United Airways and allergic march. We'll dive into the management of asthma and management of allergic rhinitis, and we'll take it on from there. So by way of introduction, the World Health Organization actually estimates asthma to account for up to 15 million daily lost years annually, which is a heavy burden. It's a high one. And of the world's population, up to 25% suffer from allergic diseases. And this can be fatal if not controlled. Actually, up to 250 million children worldwide are affected by childhood allergic diseases. So it is an important thing for us to be considering today. And a lot has been implicated: environmental exposures, inherent biologic, genetic susceptibilities, and this is also well documented. For us, the medical practitioner, what do we want to actually go away with at the end of this discussion? To be able to actually identify asthma when we see and manage appropriately. To be able to identify any related comorbidities, especially allergic comorbidities. To understand this interaction of the allergy and asthma, and then see what impact this will have on asthma and asthma control. Know how best to treat it, and when or how to refer. All right, so in terms of understanding asthma is like a syndrome. It's like a heterogeneous disease. Just the way you talk about nephrotic syndrome, you pick 1, 2, 3, 4 things. When you find it, it's most likely nephrotic syndrome, that kind of mindset. So it's a heterogeneous disease, but we know that the baseline characteristic is that of chronic airway inflammation. So it's a disease of the airway. And the main thing that characterizes is inflammation. And that also informs our choice of medication when we start talking about steroids. But we'll get to that. So when you are managing someone with asthma, you expect respiratory symptoms like wheeze, shortness of breath, chest tightness, and cough. And this vary over time and vary with intensity. And usually they'll be, backed up by a variable expiratory airflow limitation, which, you can also measure objectively to decide that. So in terms of understanding the management, we can't talk about asthma without going back to speak about GINA. GINA is Global Initiative of Asthma. They've had many publications, and recently there's also a 2023 updated guideline. So in that management wheel of GINA, it always goes through those three things: assess, adjust, review, assess, adjust, review, each time an asthma patient comes your way. So in terms of assessing, you want to make sure, is this asthma? Confirm the diagnosis if necessary using objective measures like your spirometry. You go through symptom control to be sure the symptoms are within what you want it to be. Check for modifiable risk factors. Look out for comorbidities, which is part of why we're here today. Go through your inhaler technique with your patients. Check the adherence, because without adherence, even if you increase this drug, the dosing to 3 times, if the adherence is poor, you just write prescription for yourself. Look at patients' preference for goals. Then in terms of adjusting, each time they come, again, what are the treatable, modifiable risk factors? What are the comorbidities, which is why we're here again today? What are the non-pharmacological strategies to employ? Asthma medication, skills, training in use of the inhaler, education. The patient needs to be on the same page with you as the doctor. You adjust medications based on that. And again, you review the symptoms, you review exacerbations, you review side effects of medication, you go through lung function again, you check patient satisfaction. So this is the GINA management wheel. But all the emphasis here is that looking out for comorbidities should be part of what you should think of each time you're managing someone who has asthma. So why the concern for comorbidities when we're discussing asthma? Asthma on its own is a big topic. Allergic diseases, particularly allergic rhinitis, is another big topic, and each one has its own issues where a patient is suffering from it. Now, so when you have a patient who is having both asthma and allergic disease, it's like having to bear a double burden of the effects of allergies and that of asthma on one patient. And now the presence of comorbidities increases disease severity, makes asthma control more difficult, to achieve. So it frequently will contribute to a more difficult to treat asthma phenotype. So when you having people having severe asthma, going on the higher ladder with GINA, begin to think, are there comorbidities you haven't also thought out? So without good control of the comorbidity, the outcomes for asthma are also poor. And now in the recent trending focus for research for phenotype-driven therapies, poor asthma control is seen in its own class. But always remember that poor asthma control is driven by severe asthma biology. The background may be uncontrolled comorbidities. So that is why it's important for us to bring it up when we discuss asthma even today. So what are some of these comorbidities? Okay, like we can see on this slide, there are many. The idea is not to use 45 minutes to try to go through each and every one, and we'll see where our interest will be. We're mainly on the rhinitis, but it's good to know when you're trying to take a history or find out from your patient that has asthma, what the other comorbidities you may be needing to deal with. So apart from rhinitis, chronic sinusitis, gastroesophageal reflux disease, obesity, obstructive sleep apnea, hormonal disturbances, atopic dermatitis, allergic bronchopulmonary aspergillosis, bronchiectasis, a lot of respiratory infection. And as they get older, you're thinking of COPD, smoking and nicotine dependence, a lot of psychopathologies due to their either fear of asthma or feeling ashamed because of asthma, and other issues like the hyperventilation or glottis dysfunction. So these are comorbidities that have been documented to occur in people with asthma. But we will narrow ourselves as we go on. But I want us to also think about what they call the united airways or the unified airways, where the airway from the upper airway down to the lower airway are seen somehow as one entity. That's why they're called unified. So you find allergic rhinitis, sinusitis, asthma, having common triggers, having common pathophysiology. In terms of anatomy, they are contiguous. You start from the nose of the mouth and you follow all the way down to the windpipe, your trachea, down to the smallest bronchioles, down into the alveoli. So they have also a functional linkage because you get down all that pathway through the mouth or the nose via breathing. They have similar histology. The epithelial lining, and even if you go through the embryology, the development is about in the same package. Now, the triggers, the house dust mite, the pollen, the pet dander, the mold, all that, they will affect and respond in the same way. And it's looking as if it's the same unified airway, whether it's sinusitis, whether it's asthma, whether it's allergic rhinitis. Even the same mediators are triggered when those triggers come in. They will reduce the mast cell and reproduce the eosinophils that then become the mediators of inflammation. And they go through release of IgE, histamine, cytokine, leukotriene. So all that unity makes it look as if the upper airways, as they are connected to the airway, lower airway. So treatment of one part seems to also improve the outcome of the other part. So even the same drugs, even the biologics, the anti-IgE, as we'll look through, the steroids, antihistamine. So all are in that way. So in managing one, you're doing well in managing the other parts also. I needed to bring that to fore. And also to bring to fore is what we also hear or talk about sometimes, the allergic march. Again, coming back from the same origin of the United Airways and the inflammatory cascade that is triggered. So a child who is born, who has that predisposition to IgE sensitization may actually start with things like the atopic dermatitis, and through the cascade may go down through going through food allergy, and then before you know it can then march on to asthma. And we'll see one or two studies that actually have shown ability to, cut short that progress can help prevent development of asthma. But that shows you the relationship between allergic conditions in the body. So when you're trying to manage one, think of the other so that you'll be able to have a holistic approach in managing this patient. So rhinitis is where we'll go into. And why are we going to think about that? We'll see some studies that helped us narrow our discussion of 45 minutes today to just allergic rhinitis. So what's the allergic rhinitis? It's an IgE-mediated type 1 hypersensitivity response, where the nasal mucosa in the sensitized individual then respond in that hypersensitive way that when they are exposed to allergens. And you now have symptoms like rhinorrhea, nasal block, nasal congestion, nasal pruritus, sneezing. It's been reported as the commonest comorbidity in many studies. But a lot of us underestimate it, overlook it. It goes unrecognized, is undertreated, especially in children who have asthma, and that is not good enough. In studies, it's been documented. If a patient has allergic rhinitis, 20 to 50% of them will have asthma. But if a patient has asthma, up to 80% of them will have allergic rhinitis. A few local studies that I saw, Garba et al. In Sokoto, Onubogo et al. In Port Harcourt, Ayuk et al. In Enugu, Kuti et al. In Ilesha, Zhao et al. In China, Yüksel et al. In Turkey, Kema et al. In India, all documented allergic rhinitis as the commonest comorbidity in children or the participants with asthma. Allergic rhinitis was the commonest. So for a 45-minute talk, we may have to just, focus on asthma and allergic rhinitis and see how it works out. Maybe in question and answer time, we'll be able to take more. So with all these asthma, allergic rhinitis interplay, what should the practitioner do? So you look into the non-pharmacologic things and the pharmacologic things. We'll discuss asthma, we'll discuss allergic rhinitis, which is actually the meat of our discussion today. In terms of the non-pharmacologic, we may not go into everyone, but the two important ones that are important, particularly for allergic rhinitis, is it possible that if a child has asthma and has concomitant comorbidity that includes allergic rhinitis, can we possibly find the trigger? You can try, you can ask questions, good history taking, good observation by the patient. And where you have access, please go ahead to ask for skin prick testing. This can be for aero allergens, this can be for food skin prick test. But if you have access to that, it could help you try to identify what this patient is sensitized to. And when you're able to find out, either by history taking or being able to do an SPT, a skin prick testing, you can then try to, employ, allergen avoidance. if, for example, the patient is sensitized to house dust mite, either the Terracinus or the Farina, you're able to do an allergen avoidance. The problem is that you may have multiple sensitization and you can't take the patient away from where he's living. So do your best to do avoidance, elimination, removal of whatever is the source of the allergen, washing pets if you have, animal dander, mattress covering that can, reduce exposure to whatever may be the, sensitive material, removing carpets, use of, filters. Some studies have shown that it hasn't helped much, but as much as you can, once you identify what a patient is sensitized to, that would be a good non-pharmacologic measure in managing this patient. What of going into asthma management proper? I've brought this photograph to show us different types of inhaled medications that are useful in asthma management. But the main, trust is on inhaled corticosteroids. The first row has shown the short-acting beta-agonist, your Ventolin, salbutamol. The other group is the long-acting beta-agonist, your formoterol and all that. Your inhaled corticosteroid alone, the combination therapy where there's a mix of the inhaled corticosteroid with either a LABA or something else that's help, or muscarinic agent, depending on which product you have available. Or the muscarinic agents alone, your pratropium and all that, Recipimat. Of course, asthma treatment has moved further to include the biologics, and where that hasn't helped, bronchial thermoplastic can help, your PD4 inhibitors can also help. But these are to know that there are a lot of spectrum of what is available in terms of managing asthma, but inhaled corticosteroid is your main thrust. Asthma is an inflammatory problem, and you need steroids to help handle that. Before I continue to the other medications or help us understand a little bit of GINA management in terms of asthma management, I need to also mention that, at least not as first line, a lot of medications have been, by reason of evidence, pulled off the shelf. Except you're living in the low and middle income countries where you don't have availability, and now that many drug companies are pulling out. But we need to know what evidence helps us know what best management practices for our patients, so that when we're now doing something that is less than, that we now know, at least we know what the correct thing is, just that we didn't find access to it. The oral bronchodilators, the way we give salbutamol, they have slow onset of action, they have more side effects, they are no longer being promulgated. Your oral corticosteroids, such as your, off-the-counter cheap prednisolone, except you know what you're exactly treating, how long you want to treat for a short period, is associated with serious cumulative adverse effects and is not what you should run to at your first instance. What of your chromone PMDIs? They've been discontinued globally. And what of the SABA alone, where we give Ventolin puffs alone for asthma? We'll talk about that now. As far back as 2019, the GINA guideline had already shown evidence that use of SABA alone, that's a short-acting beta-agonist, like a Ventolin puffs alone, were causing more harm than good. So if you need to use it, the way forward is to combine it with a steroid, an inhaled corticosteroid to be more precise. Use of, because you have bronchoconstriction as part of the pathophysiology in asthma, it closes up the airway. The tendency is to think, oh, it can't breathe well. So you use a short-acting beta-agonist. It causes the vasoconstriction to be released. The smooth muscle relaxes. It opens up. Short action, it starts again. So it leads to a vicious cycle, encouraging overuse. And overuse has been associated with even a resistance, increasing exacerbation, eventually increasing mortality. So as far back as GINA 2019, this fundamental change had been promulgated, and we need to keep coming to terms with it. But from the other things I've also put here, the recommendation is usually evidence-based. You may say we've not done enough of our own homegrown, and I know a lot of people are doing studies ongoing and will maybe soon publish Nigerian-based data. But this is, what is available there. What of for even mild asthma? Use of ICS formoterol. ICS, like I said, is inhaled corticosteroid. Formoterol is a long-acting beta agonist that is of short onset of action. So it works as if it's Ventolin. It works as if it's SABA, but it's short onset. So it starts. So it's a LABA with short onset of action. In combination with an ICS, even in mild asthma, it's been shown that compared to using SABA alone, it reduces emergency visits by up to 65%. It actually lowers daily use of ICS alone by 37%. So these are all evidence-based that are out there, that even for your mild asthma, we need to, think, beyond regular use of just SABA and SABA. We need to know the evidence behind it. All right. So what of your younger children? Because those questions I expect they would come up. For this studies have been done, even the younger age group. So if you have a child who is having recurrent wheezing, and each time he has a respiratory tract infection, they say all that wheezes is not asthma. Oh, could it be bronchiolitis? It could be this, could it be that? While thinking of it, and while thinking of using your SABA, which is our go-to, even a short course of that ICS. Yes, you can use inhaled corticosteroid, even with your spacer device, even for the young ones. Once you have proven that pattern, he has a respiratory tract infection, and wheezes only those times, it goes away, she's okay. A respiratory tract infection comes again. Now, the strategy that lowers the use of systemic steroid, it lowers the number of emergency department visits, is that an intermittent course of ICS at the onset of that respiratory tract infection, alongside that SABA, which you already want to use, is what you need, even for that child birth to 4 years. And this has also been documented. You go to the GINA guidelines in the box 6.5, you will see this recommendation. So going to the other age group, 6 to 11 years, why have I brought this slide? It's not so that you cram it or any sort of thing. It's just to point your attention to this. Step 1, low dose ICS. You take it if you need to take SABA. So it's not just SABA, SABA, SABA. SABA is short-acting beta agonist. So as you want to manage that asthma that you're looking at, think of your low dose ICS alongside your SABA. Step 2 means step 1 didn't help. And this child's symptoms, as you go through assess, adjust, review, assess, adjust, review. That means you now need daily low dose inhaled corticosteroid. As you step further, it's either you're now combining it with your LABA, which could be your salmeterol, could be your formoterol, and on and on, and up to a higher stage where you're now bringing in the biologics by step 5. That's why your omalizumab and some of those medications come in. But even for 6 to 11 years, step 1 is your ICS, your step 2 involves ICS. So it's ICS all the way, again, because of what I've explained as the main thrust behind what causes asthma, to then cause those cascades. So if you give SABA alone, you only end up having a short-term relief of bronchoconstriction. But whatever is causing it, which is based on the interleukin, IL-5, and the things that have been released, something needs to switch them off. And needs to be an anti-inflammatory. And that is why an ICS or the steroid base becomes useful. What of the 12 years and above? Again, those 12 years are considered usually in the adolescent and adult age group. You can see in their step 1 and 2 is joined together. It's the needed low-dose ICS formoterol in combination. So you're not trying to bring different canisters, because you know that this patient requires an ICS and formoterol. As you go up, it's either you're increasing the dose or you're heading towards now bringing in the biologics. But there, the 12 years and above are treated as adults, and from evidence, you need to actually get a combination therapy where ICS formoterol in one canister helps them, both for as needed relief and also for your exacerbations. So having gone through that brief, because it's actually a brief, there's much more in discussing asthma. The truth that in having taken that history, confirmed that you're dealing with asthma and you want to manage, in that assess, treat, adjust, and all that, you must find out whether there's a history of concomitant comorbidity, such like your allergic rhinitis. And with that history or sign, or you're able to prove it using your skin prick test and all that, you have to treat allergic rhinitis appropriately if you want to get a good outcome for that asthma you're managing. That is why we needed to bring up not just discussing asthma, but the comorbidities, because they're important. And we've chosen allergic rhinitis because of, again, how common it is in people with asthma. So just like you have in GINA, the step ladder approach in management of asthma, there's also the group called the ARIA, that the rhinology group. They also have their guideline, and the most recent is also the 2023 ARIA guideline. It's important to note in that guideline, just like you have inhaled corticosteroid as the main treatment, here is inhaled intranasal corticosteroids. That is the main treatment or the first choice for therapy in management for allergic rhinitis. Now, if you look at this step ladder approach, which I'll briefly walk us through, which will still be broken down and we'll still understand it better. Now, everything here means once you're from this ladder, you need to think through this till the end. So this is where intranasal steroid come in. But if you have someone who has mild intermittent rhinitis off and on, you may not immediately go into think of your oral sedative H1 blockers. We'll talk about them soon. Okay, your oral decongestant. We'll also talk about that one soon, because a lot of people stay there and it's not the place to stay. But always remember, first choice, particularly if you're now starting with, even though it's intermittent, it's now becoming moderate, severe, it's now causing nasal blockage, nasal, difficulty breathing, some loneliness, can't sleep well at night, ends up sleeping during the daytime. Moving on to mild persistent, moderate persistent, severe persistent, you need intranasal steroid. There are many types. Okay, so intranasal corticosteroid, they've been shown to improve asthma symptoms in patients that have coexistent allergic rhinitis and asthma. Like I said, there are many types. You have the Flixonase, you have the Avamys, there are many types, okay? They're available out there. Their prescription is out there. But the thing to note in treating allergic rhinitis is not a 2-day treatment. It's not a 5-day treatment. Most time, give those medications between 2 weeks and 6 weeks. You want to have a sustained effect of your management. So apart from the intranasal corticosteroid, you have your nasal saline. This can come in drops. This can come as spray. You can actually engage in nasal washing where the blockage is, causing a lot of discomfort. So nasal saline can and should actually be used as your first line in treatments with patients with allergic rhinitis. You can use it either alone or in combination with the other pharmacologic treatments we've talked about, because there's good evidence that supports additive effects. So they come in with what you may consider mild. Think of your nasal saline. Think of either a spray or drops you're washing. It's not controlling it. Think of your intranasal corticosteroid as an add-on. Okay? Now, I need to talk about our decongestant, because a lot of us run to it. It has this problem of rhinitis medicamentosa. In other words, you start using it and it gives you a very quick, fast effect. Your phenylephrine, your pseudoephedrine, your ephedrine, your oxymetazoline, your xylometazoline, nafazoline, depending on what trade name it now comes in. After about, if you're using it more than 5 days, more than 10 days, once you stop that drug, every of the symptoms will come back. You have that rebound effect. So the teaching really is, if you must use it, because if you start using your nasal saline with your intranasal corticosteroid, you're actually most times okay. But if you want quick relief, by 3 days, maximum 5 days, never more than 10 days, you've stopped it. And if you start it because you're still looking for access to your intranasal corticosteroid, please, once you get it, immediately replace it and have now a continued dose for up to 4 weeks of your inhaled corticosteroid, intranasal corticosteroid, so that you don't run into this problem of this rhinitis medicamentosa. I thought I should mention, because a lot of us like, this over-the-counter, nasal decongestion. Nasal saline is a good nasal decongestant. If you must use this, please back it up with your intranasal corticosteroid. What of your oral H1 antihistamine? A lot of us are already familiar with use of this. Cetirizine, loratadine, these are the newer generation of the H1 antihistamine. They don't have your sedative effects. Of all the ones that are out there in the market, because there are many more, they are the 2 most highly studied second-generation antihistamine. And they can be used either singly or concomitantly. And after my training in South Africa, I used to wonder, is it because they have access to, medical aid? They always pack so many medications for them. But I found out that if you have some of these concomitant illnesses and medications work by different pathways, you find them going home with a lot of all this. And within a short time, they get their relief. Cetirizine, also in combination with your albuterol, helps with an additive effect, giving all a bronchodilatory, effect. So it's been documented to have both as monotherapy and in combination. So cetirizine, loratadine, studied and published out there. I tried to make it a friendly slide show, so that we don't overpopulate it with this study, that study, this study, that study. But there are actually studies that prove this, and I saw them. But I thought I should mention this one, the atopic child trial. when they studied children who had grass pollen and house dust mite sensitivities, and they were treated using, so the group that were treated with the cetirizine component actually had a near 50% reduction of the risk of further developing asthma. Again, speaking to that allergic match I've spoken about. This is a well-known trial. You can Google it. So there are effects that you need to reason out and think about when you're managing this child with asthma because of concomitant allergic rhinitis, and how best to follow up and manage that child because of any knowledge we may go away with today. Like I said, we're not trying to cover all the groups. The neonates have their issue and all that, but trying to narrow it so that the practitioner knows what he's going away with from this seminar and this discussion. Now, what of your leukotriene receptor antagonists, your montelukast and zepilukast? Again, by studies, usually you can use them in combination with your topical intranasal corticosteroids. They have demonstrated benefit for treatment of both asthma and allergic rhinitis. Remember, our data said if you have 20 to 50% of those who have allergic rhinitis may have asthma. But of those who have asthma, about 80% of them will have allergic rhinitis. So you must look out for these comorbidities. You must attempt to try to treat it. You must try to address it if you want asthma control to be optimal the way you want to check with your ACT. So this is also consistent with efficacy in addressing inflammation of the unified airways. That's why we brought it up earlier. Tell you how the upper airway and the contiguous nature to the lower airway. So management of one part helps to even improve management of the other part. So we must have that in mind in use of these medications. Now, what of the biologics? Because we'll soon be rounding up, because I expect a robust interaction, because some of the questions will help us. In this, we've not tried to go into allergic dermatitis and all that, but the commonness is what we chose. The biologics come in. Again, in asthma management, if you remember that GINA guideline I had shown, the step 5. By step 5, you're moving to the biologics. Again, you move through, you've tried to manage a step 1, you've done the step 2, you've done the step 3. It's a step ladder thing. Again, the way it's step ladder going up in management is also the way it's step ladder in coming down. If you begin to get improvements within 2 to 3 months, you step down, you step down. But by the time you're stepping up to step 3, you're not getting, so you're beginning to think of this biologic, step 4, step 5. Omalizumab comes to mind. The only disadvantage is by this time they're going parenteral, and this is not usually maybe child friendly. But if you get to that point and you have to bring in a monoclonal anti-IgE antibody, you need to do that. What does it do? It binds to free IgE. Remember, IgE is what will bind to stimulate a cascade for inflammation. So when you bring something that binds, it almost removes IgE from the circulation. So it prevents that IgE from binding to its receptors that now stimulates inflammation and the cascade that then leads to all the wahala we actually see. So omalizumab being a monoclonal anti-IgE, that's what it does. And it has been demonstrated again in studies, which I probably didn't just want to overpopulate our slide with. Effectiveness separately, both for asthma, like we saw in that step 5, and also in allergic rhinitis. So when you've gone through all the steps for even the ARIA guideline for step 1, the intermittent allergic rhinitis, moved to moderate to severe intermittent allergic rhinitis, moved to all the therapies up to severe. Begin to also think of, can I bring in the biologics? And of course, when you need to do that, if it's not within your scope, there are people that can be able to handle it if you're able to find the drug available. But this again has, like I said, demonstrated effectiveness both separately and together for asthma as well as allergic rhinitis. What of allergen immunotherapy? Both the subcutaneous immunotherapy and sublingual. Again, these are things that we need to bring in to know that when you reach the end of the ladder, think of the next other lengthened ladder. And that's why immunotherapy comes in. We want to keep exposing them to that thing if you think they're allergic to, and gradually desensitize them. But these are done under, call it STP, standard temperature and pressure. These are watched procedures that you want to be able to have under control and know when best to terminate the procedure. But these are options for management of allergic rhinitis. So again, let's summarize what we've spoken about, because we've talked about asthma and we say we have to manage asthma appropriately. We've talked about allergic rhinitis, and you need to manage it appropriately. It is the commonest comorbidity, and you need to be armed to your teeth, how best not to overlook it. And this area guideline reminds us that once it's moved from, occasional, mild, intermittent, you should then bring in an intranasal steroid. So allergen avoidance, we've talked about it. Oral histamines, we've talked about them. Your leukotriene antagonists, we've talked about them. Your intranasal corticosteroid is your mainstay of therapy. Your decongestants, nasal saline, drops, spray, wash is important. But if you must use any of the pseudoephedrine and all the groups that do that, then consider not giving it for anything between 3 days and 5 days, max 10, you have stopped and switched over to an intranasal corticosteroid to have that effect. Okay, I didn't go through trying to teach us maybe how to look into the nostril to see the enlarged turbinates and all that. It will be beyond the time so I can have enough time to also interact and have a feedback and speak to how best or bring up scenarios of what we've managed. All right. So allergen avoidance, irritant avoidance, and immunotherapy becomes your last resort where you have gone through all the process and it doesn't seem to have worked out, and you start thinking of your biologics and your immunotherapy, slits and skits. All right. So in conclusion, okay, me, you, anyone seeing patients with asthma, we need to do a comprehensive asthma evaluation. Again, this didn't go into teaching us spirometry, speed flow meter, and all that. That will veer us off. And the evidence-based management of allergic comorbidities, especially rhinitis, knowing how common it is. And as much as you can remember, this slide will also be shared. As much as you can remember, apply as much. Remember the GINA wheel. You assess, you adjust, and all that. Apply as much as you can to manage these patients. And where especially this interplay exists, or where you think you can, look for the pulmonologist around who you can appropriately refer. All you're looking out for, all I'm looking out for is best results in these patients with asthma. And if they have comorbidity, we must look out for them. We must try to manage them if we are to get good results. Thank you very much. I welcome questions. Thank you again.
We thank Professor Ayuk for that very lucid presentation. We have heard from the experts. For those that have questions, kindly raise up your hand or put your questions in the chat box. While we're waiting questions, there's already one question. I wanted to quickly summarize. Someone wants, there's a question from Dr. Luwole Ayodele that says, what do you mean by combination of cetirizine with albuterol in the management?
Okay, if I understand that slide, yes. The idea is don't be scared that your patient is carrying home so many drugs. So if you're having to, albuterol is salbutamol, it's another name for salbutamol. Salbutamol with the emphasized use alone. So if you're using salbutamol for the younger child, you need to, when giving ICS, you give salbutamol. If you've also assessed and this child has allergic rhinitis, an additional of the oral H1, blockers, especially the newer ones like cetirizine, Montelukast and all. So those pathway, you can use them. They have additive effects. So, and they can help to manage that concomitant asthma allergy. I don't know whether, that answers a bit of question.
Any hands up? So to summarize, Professor Ayuk has told us the importance of us identifying asthma and managing appropriately, and that we should assess, adjust, and review using the GINA cycle. In terms of assessing, we need to confirm the diagnosis and identify the symptoms. We need to check for comorbidities. The emphasis in this instance is on allergic rhinitis. We need to adjust and treat appropriately in terms of when the patient has comorbidities, and we need to review the symptoms the patient has, check the inhaler technique, and adjust appropriately. in terms of the patient has and its importance because it increases the disease severity for those, and it makes asthma control difficult if we do not identify that the patient has a comorbidity. So the comorbidities identified, there are many, although the emphasis in this topic was in this lecture was on allergic rhinitis, but some of the comorbidities identified include allergic rhinitis, chronic sinusitis, obstructive sleep apnea, obesity, respiratory infections, atopic dermatitis, and glottis dysfunction, to mention some. And we need to understand the interaction between these comorbidities and asthma. She went on to talk about the atopic, the allergic match, mentioning starting from eczema in the early infancy, and then going on to food allergies, those that will develop allergic rhinitis, and then asthma. And that if we are able to intervene early and stop the intervene at one point, we can actually prevent the progression to the other in the ladder. And then she went on to talk about the management. Talked about the management of asthma and talked about the management of allergic rhinitis. She talked about the use of the fact, before I go on to talk about the management, she talked about the don'ts. What is it that we do not use again in the management of asthma? And that includes the oral corticosteroids, the oral salbutamol is also something that is not used, and then the short-acting beta agonist alone has been found to cause more harm than benefit, and so we should avoid the use of SABA alone. And the teaching now is to use. Please, can we mute ourselves? So, and the teaching now is to use SABA.
Rashidat, you are muted. You need to unmute so we can hear you.
Sorry, please, where did I go back to muting myself? I don't know whether you heard me initially. I was giving a summary of what she presented.
There are some questions in the chat box as well.
Stop. I'll take the questions and I can cover some of the things you're still trying to say.
So the next question says, how do we prevent pharmacies from selling oxymetazoline to children under age 1 year? That's from Dr. Orode Doherty.
Okay. Let me take it up to the very first question. The first question talked about that he thought allergic rhinitis is a part of asthma ladder or match. What I'm now saying is a comorbidity. Is rhinitis not a part of asthma process? What's the difference in their manifestation? Okay, so I'm not sure at which stage this question was asked because I tried to explain all that in the lecture. But the truth is that that's why I mentioned United Airways and explained how they are linked. It's not the same disease entity, but you find them coexisting because of all the things I've explained. Okay, so they are not. It's not like, and like the allergic match is what we also spoke about, that one thing can then match onto the other. Not that they're the same disease entity. Okay, so one can be, you have people who have asthma who don't have allergic rhinitis, but they're in the minority. You have people who have allergic rhinitis who don't have asthma, they're in the minority. And so we try to explain what asthma is and how what makes you decide someone has asthma. So I hope that answers the question. Someone said, do you mean a combination of cetirizine with albuterol? And okay, so I will try to also answer that. Okay, so that to Dr. Orode's question. The use of nasal decongestants, like I spoke about, if we have more knowledge of what they do, when to use them, and when to put an end, and how to continue something else, ours won't be to do pharmacy control. There are a lot of things in Nigeria that is not within our control. But if we have the knowledge of what we do, why we do them, when to do them, what options we have, if that's the only option we have, how long we should use it, if we have it other things, what to combine it with, then our knowledge is what, except because it's not every patient that even comes to your clinic. Some stay at home and go to pharmacy to treat other things, treat their own malaria, treat other things. But part of what this small group does is we keep increasing our knowledge. I've listened to talks on heart disease here. I've learned a lot. I've listened on talk on, enuresis here. So this is to help us improve our knowledge. Once we improve our knowledge, we're able to then, do what we need to do without running after pharmacies in Lagos. Okay. That's where you stopped, beloved moderator. I don't know, maybe
for your responses. The next question is still from Dr. Orodi. She says, how comfortable are you using cetirizine under age 6 months? If you use it, what dose do you give?
Okay. The medications, well, most times in medications, even if you pick up Avamis, most of them will tell you from 2 years and above, so to speak. A lot of drug trials, and because of the principles of ethics, not done in children less than 2 years, not done in pregnant women, not done in prisoners, not done. So a lot of the paper would always try to exclude certain groups. But if you're able to understand how this works, okay, and some medication may use some will tell you 1 to 2 milligram. Some will give you a cutoff, just like if you're using methylprednisolone or prednisolone. Once you're up to 40 kg or less, you can't use above a part, even if it says 1 to 2 milligram per kg, and this child's weighing a weight that can give you 70 kg. There are cutoffs. So most of these medications will have cutoff. So, but in terms of what you see in the labels, most, even the Avamis, will not allow you to, they'll say for use for 2 years and above. But from practice, we know that if you use it appropriately without abusing it, these medications, because I see the question is for age under 6 months, yes. Okay, so just like when you want to give Zadi-10 or you want to give Montelukast and they say, oh, it has side effects, it causes craziness, it causes psycho and all that. If you want to use steroids or methylprednisolone, oh, it causes shortening, and all that. Every drug has side effects. Even paracetamol has side effects. So it's understanding the pharmacodynamics, pharmacokinetics, and know how best, to work it out. All right. Is salbutamol still in asthma treatment? Oh, yes, it is. If you see, the idea is what is moving us away from is you try to use a medication where it is needed. Where a problem is in asthma is in the lung. If you use oral medication, it's systemic. It goes around the whole body. So if it's going to give other side effects, increase heart rate and all that, it's going to do it more with your oral that goes everywhere. If you use the inhaled form, especially if you have access to a spacer device, it reduces the quantity that goes to every part of the body. And because asthma is basically inflammatory, the magic that the bronchodilators will do to open the airway and then close back, it doesn't switch off inflammation. So in the age group that it says, if you look at those GINA guidelines, use ICS when using SABA. So use of SABA alone doesn't solve your problem. So salbutamol is still very much an asthma treatment. If you get to even the acute severe asthma and you're not getting, you can find out in many guidelines, at the end of the day, you still have to use maybe IV aminophylline, the correct dose and all that to get an effect. But this is you trying to go through evidence-based to do what will work to eventually get down. So salbutamol is still there, but used in the appropriate way as promulgated.
We have Dr. Uzodima online. She has her hands raised up.
Okay, let me just run through the question. If a patient has allergic rhinitis and asthma and requires ICS and intranasal steroid, would ICS alone be adequate to cover both conditions? The answer is actually no. They are united airway, but one is lower down. I didn't go into teaching us how to look into the nose, look for nasal turbinates and all that, because those nasal turbinates, if you ever looked at them, sometimes they are large. You have to sometimes look well. Some actually look like polyps, because that's another management on its own, pedunculated polyps. But allergic rhinitis is that blocks off the nose. If you use your steroid to have small effect, but it won't give you the effect the intranasal corticosteroids will do for you. So no, they do not. They can work as synergistic, but they don't replace each other, depending on what it is you're managing. Each is a disease on its own. Remember, that's what we said. So it's a double burden for the patient who is now having concomitant disease. So no, they don't replace each other.
The next question is by Dr. Yusuf. He says, please, in a rural setting where there is a limitation on drug use, what is the best line of management for elderly patients?
Okay, Dr. Yusuf, that's a very important question. It doesn't even just concern rural use. I don't know if you're involved in management of asthma. After GSK pulled out and a few companies pulled out, you don't need to be rural area to know that we are in their need and in a little difficulty right now. So that's why I said there are standards, and we come to remind ourselves what these standards are, despite whatever we're doing that may be working. So you look the way possible best, because I'm sure there are many other things in the rural area that are lacking apart from asthma drugs. Okay, so we'll keep telling and keep being advocates while being in management and in government and in politics, some of us, to be able to get some of these things where they are needed. The WHO list, the basic drug list, we don't even keep to it, whether in rural or urban. But yes, when you get into those difficulties, you first try to see where you can prescribe what is available. And what is available now is even further limited. So your question is important, not just for rural setting, but you will now begin to teach in a place where you're trying to teach what is standard. Oh, now, if you don't find it, go and drink a salbutamol tablet. Where you finish just saying to people the side effects are bad. But remember, I gave a caveat and said in lower and middle income countries where what is standard is not available, rather than nothing, you then use those things that are available. I don't know whether that answers you, Dr. Yusuf. All right. The other one says, do we still need to use ICS in patients with intermittent asthma? Yes, when you need, remember asthma, ICS is corticosteroid, inhaled corticosteroid, which is an anti-inflammatory. Asthma, inflammation, chronic airway inflammation. So if you use something else that is not switching off inflammation, you have not worked on those cascade. So if you are going to need salbutamol, which is what everybody wants to run to, use an ICS while doing it if you want to use intermittent. And I showed a slide where ICS with formoterol, even use intermittent, even in mild asthma. If you understand what, so I didn't go into trying to teach us what is mild, what is moderate, what is severe. If not, this lecture won't end today. But the idea is to understand ICS is what is in the pathobiology that will switch off inflammation for you. If we have to import another GSK, we have to do our own handmade local. We need to make inhaled corticosteroid, inhaled because it gets down to those receptors in the lung to begin to work faster than taking the oral one that is systemic and has more side effects. And, a lot of people use it, it works, and they now overuse it and now have other adrenaline, issues with it. I hope that answers that question. Okay, non-availability of our basic asthma medication is now the trend. Any solution from your experience? I don't have any solution, no. But I know that after GSK left, that the people that do fortide, I don't know them again. They haven't left. At least for now, they haven't left. And they also do this salmeterol. Can't remember that. I'm avoiding trade names because this is a public gathering. But they are still available. The only thing is that they've now become so expensive. And the average person, even me and you that are doctors, to afford these things is also a problem. But we're trying to say this is what to do. This is how best to do it. And when you do it, please check out whether this person has comorbidities. If he has comorbidities, please manage alongside. Don't think, oh, it's just that sniffing nose. Look into that nose and manage appropriately. Sublingual immunotherapy. I wish someone like Dr. Dusote was available to take on sublingual immunotherapy. I have watched one. I personally haven't done one. Whether sublingual or subcutaneous, these are now like the 5th level of managing, analysis has gone out of place. So I didn't emphasize on that slide. You remember, it was just a one line. I don't have personal experience. I'm not ashamed to say that. But if Odushote was here, these are the allegologists, the full-time allegologists, and we're able to help us on that. So I'm sure if he's here, we're able to help. Let me take another question. ARIA guideline. Do we use it as from moderate, severe, if the first line options fail? That is immunotherapy. No, immunotherapy, just like saying, should we use biologics as first line therapy? No, These are in step ladder. If you notice, it's in the last line that immunotherapy comes in. Immunotherapy and all the things about the step 5 in GINA are the last options. But the average patient, by the time you've done all those other steps and all the other things, will get a good relief, at least. And by the time he's needing immunotherapy, please refer. Please refer. All right. We're also seeing a lot of oral Ventolin to young children with cough. Again, what can we do as PAN to widely publicize this so that medical officers in hospitals everywhere are prescribing? How do we prevent HMOs from continuing to support this form of treatment? Well, first of all, we can invite them to be part of this a group of private pediatricians in private practice, and so that they can be learning, because a lot of information is given on this platform. I'm not joking. In all aspects of medical practice, you can get them to join. PAN is doing their bits. They also do webinar. They even did one yesterday on air pollution. In terms of knowledge, that's why we're here. We'll keep saying, we'll keep speaking. At PANCOF, for those who come to PANCOF, we'll speak, we'll keep speaking. The more we speak, the more we know more, the more we're able to learn more, the more we're able to convince ourselves, because the most difficult people I've ever had to manage, our patients, are doctors' children. If you are talking of stereophobia, it's more with even the doctor's children than the ones out there. So you're having to keep teaching and reteach even your colleagues. So it's talking, education. PAN will do their bit. When opportunity comes, at PANCOF, they'll do their bit. You tell HMOs they can join this group. I think these are the practical measures of being able to do this. EBF have strong effect on delaying introduction of foreign protein. EBF, that's exclusive breastfeeding. Exclusive breastfeeding. They have a strong effect on delaying introduction of foreign protein and asthma incidences. The neonatologists, let me not keep delving into the areas that are not mine. The neonatologists will know, but issues with foreign protein. I don't know. The children who have had need, who couldn't get onto exclusive breastfeeding for whatever reason, and have used artificial formulas that are made as near as possible as breast milk. Many of them don't come down, except they already had lactose intolerance and all that. Many of them don't really come down with this allergen. You know, the way the white man is afraid of introducing nuts, groundnuts, hazelnuts, and all that, if you've had the experience with them. Black people haven't had that issue. When your children need to start eating groundnuts, they actually start eating it without too much of avoidance from my experience. So the effect of starting exclusive breastfeeding and hoping that will delay introduction of foreign protein, I think you're talking about the milk and asthma incidences. I haven't published on that, but I'm sure that, that's why I want to quickly run through the question, hear those who want to speak, because more people who have more knowledge than me may actually be tuned into this channel. Fluticasone by GSK is scarce and expensive when you find. Is there an alternative? I think I've spoken about that. Let me not keep talking so I won't look like any company asked me to come here. You talked about treating allergic rhinitis to reduce risk of asthma. How long do you treat allergic rhinitis considering the chronic nature? Again, just like someone asking, how long do you treat asthma, or how long do you treat hypertension? Once you start a treatment for asthma or allergic rhinitis or all that, most times when I want to treat on short term for me is 2 weeks to 6 weeks, depending. Asthma, I always make a prescription of 3 months. The thing about a winning team is if you come and you say, the idea is like there is step ladder. You step up, you step down the ladder. So when it gets better, you come down. When it gets better, you keep coming down to the lowest possible dose that can maintain a near to good quality of life for that patient. Okay. Now it helps you then know where you stopped. If all symptoms come back, you step back again. That is how I deal with my asthma and allergic rhinitis patients. But I don't do 5 days treatment, 2 weeks to 6 weeks for the allergic rhinitis, 3 months for the asthma, and then we start discussing stepping up or stepping down while doing a lot of environmental modification and all that. Prof. Jolu, I hope I've answered. In the face of the increasing cost of inhaled medication, what would you advise as alternative in a setting like ours? I'm not an expert in alternative medicine or advising on alternative way. I've come to help us see the best way for our children. the best way for our adults, the best way for asthma patients with comorbidities. And like I said, there's also a publication of standard of care, lower middle income countries, which I was part of the publishers. You can check it online to see the options based on consensus of what you can do where you don't have those, what people call highfalutin, but which are evidence-based of what should best serve your asthma patient. So that paper will be able to help you without my saying, go and drink oral salbutamol or any of that. Dr. Dodu, I hope I tried. How can you manage cough variant asthma? That's now a tough, cough variant asthma is a diagnosis of exclusion. A lot of times when we've diagnosed it in our clinic, maybe in UNTH, we've tried different, it has no other symptom. Most time it comes with cough. We ruled out TB, we ruled out everything. It comes with occasional wheeze. And if you check the literature, there are different suggestions, but you still have to keep trying. Most times you're still along the line of the salbutamol and ICS for as when needed, while also emphasizing use of the antihistamines. Cough variant asthma is a bit tricky, a bit naughty, a bit not certain what diagnosis it is, but it's only thing after having ruled out every other thing. All right. Then personally contact. Difficult getting inhaled corticosteroid. What do you suggest we do? This same question. I need to keep coming up. Maybe Prof. Hey, Dr. Momaji Lawa may tell us what we may do. He's closer to the government than myself. Maybe moderator, maybe unmute those. I don't know if you have the power to unmute those who were raising up their hand. Dr. Charles Odimaz, we were raising hand for a long time now, maybe. And then probably those who have ideas. That's why I left enough time. I know it's 5 minutes past the time, but that's why I left enough time so that we can have this interaction so that people may have other ideas too. Moderator, thank you.
Thank you for that excellent presentation and response to all the questions posed. Dr. Chidima, please, can you unmute yourself? I do not have the power to unmute them.
Thank you so much.
An individual thing.
Thank you so much, Ada, for this excellent presentation.
I think
I'm here. My hand was okay. I have to bring it down. Can you hear me?
We can hear you.
Okay, thank you.
Thank you very much, Ada, for this excellent presentation. So oftentimes in my clinic, I have children, especially older ones, who come with chest pain and are sent to the cardiologist evaluating for chest pain. And often, I find that some of those children have asthma. So I just want you to speak because I know you have a greater experience with respect to adolescents who are presenting with chest pain for asthma. I would be very grateful if you can speak to that. Then, secondly, is also, I think you've answered it, so let me leave it. That's the issue of the cough variant, asthma. I think you've answered it, but the other one of the chest pain, yeah, thank you.
Okay. There are 4 main symptoms of asthma, which can occur: variability, intensity, and all that. Cough, fast breathing, chest pain or chest tightness, and then, wheezing. And the most consistent usually cough and the wheezing, but the other ones can also be there. My advice would be, they send it to a cardiologist, do a lung function test. Those adolescents can blow well and give you a spirometry, can give you an idea of what exactly is going on. Okay, some guidelines, like maybe the British Thoracic Society and some of the European Society, may say do a trial of the corticosteroid. But before you even start any trial, just get a baseline lung function and see whether it makes any difference. If you do a bronchodilator response to them, if there's asthma there, it will show. Even if the first lung function you do is normal, a bronchodilator response that is more than 12% of variability will help you know what is causing that chest pain. Because again, chest pain is a vague symptom. It can belong to anything. Okay, apart from the adolescent, especially the adolescent female can come with a lot of Murchison syndrome and all the, things going on in their life. So sometimes I've had to do a lot of psychotherapy to be able to even find out the other issues that may not be really asthma. But that's how I'll go about it. Dr. Nzadima, I don't know whether that helps.
Okay, right. Yeah, thank you.
I think there are no further hands up. A question that came in, the last question, speaking about environmental modifications, what are some of those that you can advise in a community?
Well, you start by advising the home before I advise the community. If the community is a place where they do palm fronts and they burn a lot of fossil fuel, and you're not about to produce or provide clean fuels. If you listen to yesterday's pan talk by Professor Joyce and Dr. Peter, you can't do much. Start from the home to advise and then move out, okay? Because if you have sensitization, if you're able to do a skin prick test and find sensitization to things you can identify, then you can do some of those lifestyle modification around the home. The pegs, the beds, the beddings, the rug, the cleaning of the air vents of the AC, the fan, some of those modifications around the home. I once had a patient that they actually had to move out from the house where they lived in town because their landlord, the vent of the generator was right on their window. They couldn't do anything about it. The next compound was a paint fume industry. They couldn't do anything about it. They had a lot of things, and this child had near fatal asthma each time. So they eventually had to move house to at least a semi-urban or semi-rural to be away from there. People have done different things that they can fit into to be able to manage. I think start from inwards. I know how you take it from there. All right. Thank you very much.
Thank you so much, Professor Ayuk, for that excellent presentation. We have enjoyed your presentation, and for any further questions, they'll interact with you personally. Our time is fast spent. Professor Ayuk has taken us through how to identify asthma and manage it appropriately using the GINA cycle. And she has told us about the comorbidities, and with the emphasis on the major comorbidity, which was allergic rhinitis. She has told us how to understand the interaction, and that for allergic rhinitis, we need to treat it appropriately so as to get a good asthma outcome for those that have a comorbidity, a concomitant asthma and allergic rhinitis. And she has told us how to manage asthma very, very fast. And she had 45 minutes to do that. So she had to take it in that 45 minutes, and she has told us about the area guidelines also, with the emphasis on how to use the nasal saline as a decongestant and to avoid what's it called, the drug pharmacology decongestants and the side effects. If we have to use, we have to use for less than 10 days. And she told us about the no-nos. The no-nos are the ones we avoid, we do not use again, and those include the oral antihistamines, the oral bronchodilators, medications no longer advocated for use in those that have asthma, the oral corticosteroids, the chromometer dose inhalers, and SABA alone should not be used in isolation for those who have asthma. Thank you, Professor Ayuk, for your presentation. I hand over to the chairman of the occasion.
So thank you very much, moderator, Dr. Ibrahim, for an excellent job. And I can't thank Professor Ayuk enough for a very, very good presentation, very lively presented. And I can't believe that, in a festive season such as this, we had a full house, 100 people throughout the session, many people on YouTube. I can't believe it. I don't know whether they came to see the latest professor or whether it is the lively way she presented it, or is the topic, and I think it's all of the above. So I thank the presenter very much for a job well done. I thank everyone for sparing time during this season to attend. I'm very, very pleasantly surprised. I was a bit apprehensive at the beginning that because of the season, we may not have enough people. I just a comment on the issue of finance and cost of treatment, etc. I think when generally we find ourselves in this type of situation where the cost of treatment is becoming burdensome for when people pay out of pocket, a few things come to my mind which I can share. I think one of the first things is that we need to look more into prevention, into what are the things that we know that can prevent these attacks. And usually when you go very detailed into the history, you are able to discover some of the triggers and some of the things that you can do to prevent these attacks in different children. The other part of it is the link with acute rhinitis and sinusitis, and treating those conditions easily will prevent the attacks. Considering the cost of the treatment itself, I think we just have to continue to put pressure on government to put more money into health and make healthcare universal healthcare, such that these children don't have to pay for treatment out of pocket. That is the only way they can afford it. And finally, on the issue of giant pharmaceuticals leaving Nigeria, I think it's a challenge and an opportunity. I see an opportunity for local entrepreneurs in that, so long as the government is aware of its responsibilities and is able to rise up and support them. There is nothing that is impossible. And the fact that those companies have left Nigeria does not mean that they cannot collaborate or cooperate with somebody else who wants to do the work here and take all the risks by himself. Government just have to come in and know that we have to let the government know that there's a problem in this place, their attention is required, entrepreneurs are there and they are ready to do it. And we can do it. We can begin to manufacture those things here by ourselves. So those are just my own little comments, because I think the speaker asked me to make some comments. So thank you, everyone. It seems like Dr. Eletu wants to say something. I'll hand over back to you. I wish everyone a happy new year 2024, and we resume our meetings last week of January. Thank you very much. Over to Dr. Eletu.
Thank you very much, Chair, for the summary. And also want to write on your comments to thank everybody who's participated in this meeting. We had over 100, and we had to speed over to the YouTube channel, and there are quite a lot of people there as well. Some of the questions you answered, Adaeze, were from the YouTube channel that we had to copy onto the platform. So again, I want to say thank you to you for accepting to be our last presenter for the year 2023. And I want to wish each and every one of us a prosperous new year. We meet again on the 25th of January 2024. That will be shortly after PANCOF. And as a PANCOF Lagos LOC chair, I'm inviting all of us to join us in Lagos. And I promise that you'll have an exciting time, just like you've had this evening. So 25th of January next year, we'll meet again. And a big thank you to each and every one of us. Have a wonderful new year ahead of you. Thank you. God bless.